So good morning. My name's Thomas Lee. I'm one of the maternal fetal medicine physicians at Northwest Perinatal. And today I'll be talking about marijuana use in pregnancy as part of the MFM Express Didactics or MEDx lecture series. So what I plan to cover this morning include a brief synopsis of marijuana use during pregnancy. Really what I want to do is provide you the current research on outcomes, recommendations from our national societies, and some resources to assist in patient counseling. Of note, what I won't be covering today are things like DHS reporting in Oregon, cannabinoid hyperemesis syndrome, which is becoming more common, and CBD use during pregnancy. So to start, let's talk about prevalence in general. Overall, the rate of use in pregnancy across the country is on the rise, as everyone knows. This coincides with the expansion of legalization across the U.S. in general. Currently, 10 states, along with the District of Columbia, allow for both recreational and medical use. Additionally, 32 more states permit medical marijuana use only. And this is likely to rise as there is broader legalization of marijuana use across the country, that being the trend. So what did the studies show about marijuana use in pregnancy? Well, according to longitudinal data by the National Survey on Drug Use and Health, use of marijuana in pregnancy has nearly doubled between 2015 and 2017, going from 3.4% to 7.1%. And these data are solely based upon patient reporting alone. Another study in a Northern California Kaiser population examined marijuana use using both self-reporting and toxicology data. They demonstrated an overall rise in pregnancy use from 4.2% in 2009 to 7.1% in 2016. And if you break down these data into age-stratified subgroups, the prevalence of marijuana use reaches as nearly as high as 22% in pregnant patients under the age of 18, and this trend persists for pregnant moms under the age of 24 at 19%. So this would suggest that 1 in 5 of your younger pregnant patients is likely to have used marijuana at some point during their pregnancy. Now, factors that have been associated with marijuana use in pregnancy include things like younger age, lower income, and concurrent substance use. In fact, 85% of marijuana smokers are also cigarette smokers, which, as you will see in the subsequent data, significantly compounds much of the outcome information that we have available. Overall, though, there's a general trend for decreased marijuana use over the course of pregnancy, going from about 9% in the first trimester to about 2 to 3% in the third trimester. However, nearly half of pre-pregnancy users continue to some degree to use marijuana over the course of their pregnancy. So why are we seeing these trends? Well, this is likely due to a number of reasons. One factor may be the perception that the risk of marijuana is low in pregnancy. Longitudinal data, again from that NSDUH database, suggests that the perception of marijuana use having, quote, no risk in pregnancy has dramatically increased over time. When patients are asked the question, how much do people risk harming themselves when they smoke marijuana once or twice a week? The prevalence of the no risk response has dramatically increased from 25% up to 65% since 2005 in those moms who continue to use marijuana during pregnancy. But what's also interesting, and this is the lower portion of the graph, is that there's a similar increased perception even in the no risk population, going from 3% up to 16%. So the perception that marijuana use in pregnancy has no risk appears to be remarkably common. Another factor may be the perception that marijuana is better for controlling nausea and vomiting during pregnancy. If you look at data comparing the increasing prevalence of marijuana use over time, this suggests that those patients who continue to use marijuana report higher rates of nausea and vomiting than those without symptoms. So women who have nausea and vomiting, 1 in 10 of them are likely using marijuana. Now, while marijuana has been shown to be similar to Zofran for controlling nausea symptoms in RCTs involving patients receiving chemotherapy, there's no evidence currently that supports the use of marijuana to reduce nausea, vomiting symptoms during pregnancy. Just to note, other potential medicinal uses of marijuana that are out there include things like appetite suppression, pain relief, improving sleep, use in seizure disorder, and also with PTSD. So what's the impact during pregnancy? Well, it's never good when you start with a limitation slide, but I think it's important to take these things into consideration when we look at the overall data. First, much of the available research doesn't actually quantify the amount of marijuana use. So identifying a dose relationship with outcomes is going to be difficult. Secondly, most studies rely heavily on self-reporting, which likely underestimates the prevalence of use in the population. Additionally, it's very difficult to isolate the independent effects of marijuana versus other substances. Remember, 85% of marijuana users are likely to be tobacco users too, not to mention other illicit drugs. And then finally, as the graphs to the right demonstrate, the potency of marijuana has significantly changed over time. These are data from one study that looked at the percentage of psychoactive delta-9 THC from seized DEA marijuana samples over the last 2 decades. And as you can see in the upper graph, the percentage of THC has nearly tripled over the last 2 decades. But what's also interesting is that during the same period of time, the percentage of CBD has decreased, leading to a substantial change in the ratio of THC to CBD. So yikes. So all of these factors are important to keep in mind when we're looking at the studies that I'm about to present. So let's get to the available data. There are 2 major systematic reviews that are typically cited when we're looking at marijuana use in pregnancy, which are both represented in the presented figure to the right. The first is by Gunn from 2016, which included 24 different studies. Their analysis included studies of marijuana use, which didn't exclude for tobacco or alcohol use, but did exclude for other illicit drug use. After adjusting for confounders, which are many, like smoking and other factors, they concluded that marijuana use in pregnancy was associated with 1, a mildly increased risk of maternal anemia, and 2, an increased risk of low birth weight and NICU admissions, but none of their other outcome measures that they were looking at. The other systematic review was conducted by Connor, and they looked at 31 studies. So in their meta-analysis, they attempted to account for the amount of exposure and concurrent tobacco use. However, they could identify no increased risk for low birth weight, preterm delivery, or any of their secondary outcomes, which is in the fine print at the bottom of the slide. But to further highlight the impact of concurrent tobacco use, here's an additional study by Chavarria. What they found was that there were increased risks for preterm birth, small head circumference, low birth weights, and preeclampsia in marijuana users that actually also smoked. But when you then adjusted for concurrent smoking, no increased risks were identified for marijuana use alone. So this again highlights the confounding impact of smoking on outcome measures which solely look at marijuana's impact on pregnancy. If we then turn our attention to things like newborns and early childhood outcomes, again, the data are limited. One study by Daughters Katz, and this actually was a secondary analysis of the BEAM trial, which is one of the magnesium neuroprotection trials. They examined neonatal and neurodevelopmental outcomes within their study cohorts for a number of different measures, but they could identify no increased risk for babies exposed to marijuana during pregnancy. So going even further out to look at any possible longer-term impacts on the children, the majority of data come from 3 longitudinal studies: the Ottawa Prenatal Prospective Study, the Maternal Health Practices and Child Development Study, and then the largest one, which is the Generation R study out of the Netherlands. Of course, long-term studies such as these have inherent limitations. Again, they rely heavily on self-reporting of marijuana use. And then additionally, it's really difficult to control for both familial and environmental influences when you're looking at neurodevelopmental outcomes. But that being said, here's a really nice summary by Tori Metz that was just published last year on some of the various findings. In totality, the findings suggest potentially a variety of longer-term effects. These include things like attention difficulties and memory problems, and also potentially some mildly decreased academic performance and cognitive function. Well, let's turn to kind of the question of breastfeeding at this point. What do we believe the impact of marijuana during breastfeeding is? Well, what we do know is that delta-9 THC is transferred into the breast milk, and this reaches concentrations of about 1 to 2.5% of maternal levels, and typically peaks at about 1 hour after exposure. Unfortunately, again, there are limited data on outcomes, and really trying to separate marijuana use during pregnancy from solely while breastfeeding is going to be difficult. However, 2 studies have looked at outcomes. A study by Tennies found no difference at 1 year of age in both growth or Bailey scale scores. However, a study by Astley in 1990 did demonstrate a decrease in Bailey scale motor scores at about 1 year of age. But that is the extent of the data that's out there right now. So, to put this all together, and again, this was adapted from that really nice article by Tori Metz. First and foremost, here are the conclusions. There is no clear, substantial evidence that suggests that marijuana alone in pregnancy causes any detrimental effects on obstetric outcomes or long-term newborn or childhood outcomes. Secondly, there is some mixed data to suggest that use in pregnancy may increase the risk of stillbirth, preterm delivery, and lower birth weight. However, again, many studies reporting this and other studies kind of not seeing this effect. Thirdly, there is even more evidence to suggest that marijuana may impact longer-term neurodevelopmental outcomes, especially attention problems, cognitive function, and academic performance. And then finally, use of marijuana while breastfeeding may possibly impact early motor development, but again, based upon limited data. So based upon the limited research that's out there, this is what our national organizations have suggested as an approach to counseling patients using marijuana during pregnancy. So ACOG recommends, first, ask about use in pregnancy, counsel your patients about the concerns of potential adverse effects of use during pregnancy, and discourage the continued use of marijuana both during pregnancy and while breastfeeding. The American Academy of Pediatrics takes a similar approach to recommend not using marijuana both during pregnancy and while breastfeeding. However, they go a little bit further to admit the lack of safety data and definitive research. Furthermore, postnatally, the AAP cautions about environmental infant exposure to marijuana smoke. So, to summarize, the data are inconclusive, yet the avoidance of marijuana during pregnancy are the national recommendations. So we, as providers of care to pregnant women, many of whom are using marijuana with greater regularity, as their providers, it's important to ask the question of marijuana use in pregnancy, present the limited data, and provide counseling support as appropriate. There are 2 studies that have demonstrated that patients that use marijuana but receive substance abuse counseling can have a significant impact upon continued use. Studies by both Foray and Mark have demonstrated that ongoing marijuana use during pregnancy was significantly decreased with education and counseling. So resources that are currently available to us to help you speak to your patients about marijuana and pregnancy, here is a link to an FAQ for patients that's presented by ACOG. Oregon has a single handout on its website. And then finally, what I've seen as being the kind of most robust resource actually comes from Colorado. They have fact sheets for patients during pregnancy and while breastfeeding. These actually come in multiple different languages and even comes in Korean. And no, that is not me. So thank you for your attention, and happy to take questions at this point.